Welcome to EuroPCR 2021. Welcome to this expert session. My name is Nicolas van Mieghem from the Erasmus University Medical Center in Rotterdam, and it's a true pleasure to be joined by two experts, Fabian Bras from the University of Bern and Peter Ludicke from Essen University. In the next 15 minutes or so, we're going to discuss a transcatheter edge-to-edge repair system by Edwards Life Sciences. This is the PASCAL system because there has been a lot of changes going on in the space of TEER or transcatheter edge-to-edge repair. Just to give you a brief heads up on the portfolio, Edwards Life Sciences started with the CardioBand system, which is a annuloplasty device in 2015, and then changed or introduced transcatheter edge-to-edge repair with PASCAL in 2019. In 2020, we saw then a new device, a device iteration, which is the PASCAL ACE, and we're going to zoom in on PASCAL and PASCAL ACE. So first up, I would like to ask Fabien to give an overview of PASCAL and the new features within PASCAL ACE.
Thank you very much, Nicolas. Thank you, Peter. It's a pleasure to be here with you and discuss this very interesting topic. So, you know, as you mentioned, Nicolas, I think there was a need for development in that domain, and the apparition of new device is a new technique as well is something that will benefit our patients. And if I'm thinking of the complexity of the mitral valve in comparison, for example, to the aortic valve, I think there is space as for in the TAVI space for different devices to be able to better address the anatomy, the complex anatomy in some of the patients we treat. So, you know, the PASCAL device has some special features, I would say, and one of them is a central spacer, which is actually intended to on one side to fill the gap inside of the regurgitant area, but also to reduce a bit the tension on the leaflet. One of the other features I also like, and we may discuss this a bit with Peter and you as well, is the elongation of the device. You know, in some situation you can be trapped or in interaction with some of the chordae, and the ability to elongate the device completely is something that can be very useful in this kind of situation. The device from the design is from nitinol, so it's a very flexible device, and sometimes you can see when you implant it, you can see it moving with the leaflet, and so this is also something that may have a very physiological effect on the leaflet. And finally, and that's something also very important, the PASCAL device was actually the first one to introduce independent clasping, independent grasping of the leaflet, and is probably also something that most interventionalists use today. And there has been, as you mentioned, a second size, a smaller size of the device that has been introduced quite recently, because the PASCAL, the original one, is quite a broad one from the beginning, and the ACE has some interesting features to be combined or used separately from the original PASCAL device. So it's a bit narrower. It has a small spacer, which is smaller than the original PASCAL. And it make a little bit of navigation, and also I would say the artifacts produced on echo a little bit less than with the big size of the device. It has newly also a stabilizer, because some of the limitation we have to mention on this system are probably some of unintended movement, or the less stability, which is actually an advantage because you have more flexibility. But this limitation will be a little bit addressed by this new stabilizers that has been introduced just a few days ago. So I think that's the most important feature of this platform for now.
So Peter, in your opinion, how clinically relevant is the introduction of PASCAL ACE? In other words, do you see a high uptake of this device iteration?
Well, first of all, I need to confess that we started to primarily use the PASCAL device because when the PASCAL was entered the European market, no one knew what will the indication be. And so we decided to start a prospective clinical trial to validate this at our center, and started to treat every mitral condition with the PASCAL device. And so we gained a lot of experience, and all the features Fabienne already mentioned changed over time. In my opinion, what is important and what part of the procedure improves with PASCAL. And I think when I need to highlight a certain feature of the PASCAL device, then this definitely has changed over time. And when at the very beginning, we were very focused on functional MR and the effect of the central spacer, we learned more and more that the supposed to be safety features of the device, like the independent grasping with the single row of the retention elements, which are very atraumatic, are not only safety features, but also help you to improve the procedure, because you learn to work very precisely. You try to optimize your results in every single case. And at the very beginning, it was just a technical challenge to introduce this new device, and in the meantime it has become a challenge to create absolutely perfect results. And I think all the aspects that has been mentioned at the beginning come together to make this a very interesting technology, and I think it can be a game changer for the future.
What is the relative proportion of PASCAL ACE and PASCAL in your practice? Do you use more PASCAL ACE, or do you still prefer the original PASCAL?
This is a very interesting question, and this is something that definitely changes from center to center. On the tricuspid side, the PASCAL ACE rate is 100% now, and on the mitral side, I would say it's still 80 to 20%. What we don't do in the meantime is to mixing the devices. So when we started with PASCAL ACE in the mitral side, then we stay with PASCAL ACE. When we started with the former PASCAL device, the PASCAL 10 device, then we stay with PASCAL 10.
Okay, so transcatheter edge-to-edge repair has gained a lot of attraction this year, also with this recent ESC consensus document that followed MITRA-FR and especially also COAPT. Maybe it's good to briefly look at the scientific background of PASCAL. Fabienne, the CLASP prospective study, anything new there? I think there's follow-up up to 2 years now.
So exactly, Nicolas. So the CLASP study has been the study that allowed actually the PASCAL device to gain CE mark. It's a single arm but core lab adjudicated study. And I think what we can see here on the long-term data, that we have a durable result, which is actually for a first generation device, because we don't need to forget that actually this device is the same as we have been implanted in 2016. Actually, that was the first in human of the PASCAL device. And what we see is an about 97% reduction, or 97% of the patient having a reduction of grade 2 or less with that device. That correspond actually to what we know from other experience. And what is also quite impressive for this first generation device, that we see an about 80% reduction to grade 1 or 0 mitral regurgitation that was sustainable until 2 years in the CLASP study. So I think encouraging results for this device.
And Peter, how does that translate into everyday practice? So there are some real world experiences. How is it? What is your opinion on that?
Well, Edwards provides a commercial data set because all the proctors report the acute results after the procedures to a central database. And this is a database, the biggest database to date, of more than 2,000 cases with after the CE mark now. And it's impressive to see that they reflect the study data. So it's despite a lot of the centers are just starting with the new technology, they are able to create excellent results. And there is an analysis that shows that it takes up to 25 cases that you work on a really excellent level with this new device to gain a result of 0 or 1 plus in more than 80% of your patients. And when we look on the first real data from a German data set. This is already published from the Cologne group, or a recent publication from the colleagues from Badenhausen. You can see that these first results translate also into clinical trials, and it will be interesting whether this will be also the case in the randomized clasped studies.
Yeah, I think it's already important that the favorable clinical data from the prospective clasp study are reproducible in clinical practice. So that is an important finding, I guess. Back to you, Fabien. We all know that we have functional MR and degenerative MR. Are those both targets for the PASCAL, or do you need to be more selective with PASCAL?
No, I think, of course, you can use this device with both type of mitral regurgitation. There is no limitation for that. And in particular with patient, I'm thinking of secondary MR, with patient with severe tethering, you will be, in some case with P10, with the original one, you will be very confident in clasping the leaflet. Regarding degenerative MR, I'm even, for some complicated anatomy, actually, the first study that has been done, and the first in-human study has been actually done in patients with challenging anatomy, which were not, where a perfect result was not expected with the mitral clip. And I think this device is absolutely able to reduce MR in that patient in a very safe way. And I think that's one of the important message. With this device, you are able to reposition, as Peter mentioned. You are able to optimize leaflet grasping in a very atraumatic way. And I think in particular with the P10, but also with the ACE device, because of the nitinol design and the way also the device is closing, it's not an active closure, it's a passive memory of shape closure of the device. You can use it in challenging anatomy. And we typically, when we are concerned about tension on the leaflet, if the leaflet is very short, or if mainly the posterior, or if you have calcification on the leaflet, then in some situations we prefer to use the PASCAL device to minimize the risk of leaflet damage.
So this technology also seems attractive in the tricuspid space. So what about PASCAL for tricuspid regurgitation, Peter?
Well, this is something I mentioned at the very beginning. This PASCAL ACE is our working horse on the tricuspid side, and all the features that were mentioned by Fabien just in his last comment come together on the tricuspid side, especially on the tricuspid side, because the atraumatic working is something that is really impressive. Even in octa and nonagenarians, you can clasp a lot of times into this very degenerative valves, and I've never seen a laceration. I've never seen a tear in the valve, and I think this is an important aspect, especially when we work on the tricuspid side, where we have this very filigree structure of the valve. So I think this comes together with the option to elongate the device, to free you when you entangle with the chordae. So I think it's perfectly suited to work on the tricuspid valve.
Okay, so with that, I think we can wrap up this expert session. I think it's fair to say that the PASCAL device is a very attractive technology that introduced these new features of the spacer and separate clasping. I think acute procedural success is quite high, and we're also seeing durable results. With that, I'd like to thank Peter and Fabien for their participation in this session, and I'd like to thank you for your attention. Thank you very much.